Greetings, everyone, and welcome to another episode on Oral Pathology 360. If it's your first time or whether you have been here before, it's generally very great to have you. We are always waiting for Tuesdays for exactly the same reason. Today we have a recorded lecture, but we are also announcing the results of the giveaway we had for the masterclass. Anyways, so if it's your first time, I'm Dr. Mandana Donahue, the founder of Oral Pathology 360, which is the oral and maxillofacial diagnostics community on the web. Now we have lots of upcoming news, and for that I would request you to stay on till the end and we will see it then. But today's lecture is odontogenic carcinomas and overview, keeping in mind the new classification. Wow, okay, sorry. The WHO classification that occurred recently, and it is by Dr. Yameli Vasquez. Now, this was a part of our international conference which we had, and as you must be knowing, some of the slides I have been some of the lectures we have been bringing to you slowly over time. With that, let's just go on to the lecture.
Dr. Jamali Ruiz Vasquez is Professor of Oral Pathology, Oral Medicine and Oral Biology at the School of Dentistry at the National Autonomous University of Mexico. Dr. Vasquez's research speaks of her interest in rare epithelial, which have greatly contributed to the repository of data on oral and maxillofacial pathology. She has a keen ability to delve deep into pathogenesis of oral diseases. It is with great pleasure that I welcome Dr. Vasquez to deliver her lecture.
Good day to everyone. Before starting, I want to thank to the Oral Pathology 360 organization for inviting me to this event. And a special thanks to Dr. Mandana Donahue, Dr. Jerónimo Lazos, and Dr. Mariana Villarroel. Thank you very much. I'm glad to be here with you. The name of this topic is an overview of odontogenic carcinomas, rare entities in the differential diagnosis of odontogenic tumors. But before I start talking about the odontogenic carcinomas, I want to remember us that in this year appear new changes, and the change is basically the new classification of head and neck tumors of the World Health Organization. So 5 years later, the 5th edition of the World Health Organization classification of head and neck tumors of 2022 comes out. The difference between the last classification of 2017 and the new classification is that that new has molecular information about the tumors. And this information is basically related with the treatment and the pathogenesis. And specifically talking about the odontogenic tumors and odontogenic carcinomas are related with the pathogenesis. The odontogenic carcinomas is a group of malignant epithelial odontogenic neoplasms that are an uncommon group. In the classification of 2017, this group was added in 3 groups, subgroups. The odontogenic carcinomas that were included the 5 lesions, odontogenic carcinomas, carcinosarcomas, and odontogenic sarcomas. In this new classification, there is not this subdivision that we saw in the last one. So we have 7 lesions, and these 7 lesions, the 5 odontogenic carcinomas were included. The first lesion that we're talking about is the sclerosing odontogenic carcinoma. This is a primary intraosseous carcinoma that was recently defined in the 2017 World Health Organization classification of head and neck tumors. This lesion have an sclerotic stroma and has an aggressive infiltration, and a few cases at the moment has been reported. The systematic review of this year show that only 14 cases were reported. The male-female ratio is 1:1, and at the image, we can see a radiolucent, poorly defined image with a cortical destruction, tooth resorption, and the patient can refer pain or paresthesia. Typically, the localization of this tumor is in the premolar and molar regions in the mandible, and this is a diagnosis of exclusion. In the histopathological findings, we can see coarse, nest, and piles of epithelial cells that mimicking odontogenic rest without keratin differentiation in a background of sclerotic connective tissue stroma that we saw in this background. The cytoplasm of these cells may appear clear, as we can see in these images, with abundant eosinophilic stroma in another cells. The mitosis and nuclear polymorphism are rare, and the invasion of adjacent cortical bones, the tooth root and musculature, as well as the perineural and perivascular invasion are common despite the low grade of the histology. About the immunohistochemistry findings, these lesions are positive to cytokeratin 5 and 6, ecadherin, and cytokeratin 19. The treatment and prognosis for this lesion, this is a low-grade carcinoma, but the surgical resection is a treatment for election, histologically resembling an ameloblastoma, and is not the counterpart malignant of it, as was reported in the last classification of the head and neck tumors. Now, in this classification, is considered a primary odontogenic carcinoma. This is one of the most common odontogenic carcinomas that represents the 30% of the malignancies, tumors, odontogenic tumors, but represents less than the 1% of all odontogenic tumors. So it's the common for odontogenic carcinomas, but is a rare tumor. It's more common in the mandible. The 80% of the cases presents in some posterior zone of the mandible, and we can see expansion of the jaw. These lesions have grow rapidly and perforate the cortex. The patients can refer toothache, ulceration, trismus, pain, and facial asymmetry. And the image, we can see well-defined unilocular or multilocular radiolucent lesions. In the histological findings, we have variable features of ameloblastoma. We saw in one areas the palisading, the reverse polarized of the nucleus, and the zones that remember the stellate reticulum. The atypia, it's not a specific finding as the same like necrosis, hyperchromatism, and mitotic activity, but it's important to see and find these areas with moderate cellular or nuclear atypia. About the immunohistochemistry findings, these lesions are positive for SOX2 and has a high grade of immunoexpression of Ki67, and the BRAF V600E mutation is found in this tumor that we can show or look for them for immunohistochemistry or using another techniques like PCR or FISH. This is a case with a female, a 46-year-old female, has a swelling of the gum on the left side of the mandible. So the biopsy was performed for this lesion, and the histopathological findings was the presence of these islands of these nets of epithelial odontogenic epithelial cells, but has this basal appearance and other zones of more clear. But we saw the palisading that was a finding that it's important in this lesion, zones with necrosis and atypia, and a high power, we can see the increase of mitotic activity. So with these findings, the ameloblastic carcinoma, the diagnosis of ameloblastic carcinoma was made. The treatment and prognosis of this tumor was, for the diagnosis, it requires the clinical and radiological and pathological correlations, and the overall survival to 5 years after the complete surgical remove is the 17%. The local recurrence is high, it's the 40%, and the presence of distant metastasis is high also, like the 33%. The third lesion is clear cell odontogenic carcinoma. This is a really rare tumor. Only less than 200 cases were reported. And this is a malignant tumor that has a specific translocation in the EWS1 gene rearrangement that is found in the 80% of all the cases. The age of the presence of this tumor is in the 5 and 6 decades of life, with a mean age of presentation of 60 years old. The female male ratio, it is more common in females with a ratio of 1.5 to 1 and inclusive to 2 to 1. The localization is mandible in the 75%, and clinically we can see a swelling with loosening of the teeth. It can be painful or asymptomatic, or sometimes associated with paresthesia. And in image, we can see a poorly defined radiolucency with cortical destruction of the bone. We saw the proliferation of sheets that trabeculate or islands of cells, but these cells have a vacuolate and clear cytoplasm. This is the characteristic of this tumor. Also, these cells has a well-demarcated cell membranes, and the nuclei are dark, smooth, and irregular. Also, we can see a biphasic pattern in this tumor. We saw, the proliferation of the cells with clear cytoplasm, with the vacuolate cytoplasm, but in other zones, we saw the proliferation of cells with eosinophilic cytoplasms, or inclusive some areas or zones that remember the ameloblastoma conventional. The mild atypia is a finding, and few mitotic activity is characteristic of this tumor. For the immunohistochemistry findings, these lesions are positive for cytokeratin, pan-cytokeratin, and EMA. The recurrence rate for this lesion is high, is the 40% after the surgical resection, but with more conservative treatments like curettage or enucleate lesions, the recurrence rate is higher, is for the 87%. The regional lymph node metastases are more common than distant metastases, and the death rate is about the 11%. Another tumor is the ghost cell odontogenic carcinoma. This is a malignant epithelial tumor with features of calcifying cystic odontogenic tumor with, in combination, dentinogenic ghost cell tumor. This is a really rare or really uncommon tumor, because only less than 40 cases were reported in the literature, and most of these cases are from Asia. These tumors are more common in males, and a difference between the other odontogenic carcinomas is the localization. This tumor prefers the maxillar between the mandible, but can present on the mandible. And the presentation can be painful with hard swelling and maxillary or the mandible, and can also have another symptoms like paresthesia or be associated with root resorption or tooth displacement. The image show a mixed radiolucency or radiopacity with ill-defined margins. But the histopathological findings are very specific. We saw areas with ameloblastic, remember the ameloblastic epithelium, with the peripheral palisading, with the reverse polarization, and with zones that remember the stellar reticulum, as we can see, disposed in cords that anastomose each others, and areas with the presence of ghost cells. And these ghost cells can be calcified. Sometimes there are deposits of calcified material that remember dentinoids, and in a high power, the atypia, which changes synchronous of the cellularity, the presence of pleomorphism, the increase of mitotic activity, and the presence of necrosis of infiltrative growth are another regular findings. For this tumor, the immunohistochemistry is positive for pan-cytokeratin, for P63, for P53, and the index of proliferation, Ki67, is high in these tumors. Also, we saw the aberration of WNT signal effect with translate in the beta-catenin overexpression that we can be found or show in immunohistochemistry also. In this radiographic image, it has a radiolucence radiomix lesion with yield borders in the anterior area of the mandible. This lesion in the tomography, computerized tomography, has a perforation of the cortex. Pathological findings was the proliferation of coarseness of ameloblastic epithelium or ameloblastic-like epithelium. But as we saw in these zones, the presence of this calcifying material that in high power, we saw that is in some areas, dentinoid-like material, but in high power, we saw the presence of these ghost cells in combination with the proliferation of these coarseness of epithelium. But in other areas, these cells has a high-grade proliferation with the high hypercellularity and presence of high mitotic activity, pleomorphism, and the hyperchromatism of these cells was also so. We made Ki67, we made pan-cytokeratin, and P63, and all of them were positive, and also made bone cosa. Diagnosis of ghost cell odontogenic carcinoma was made for this lesion. About the treatment and prognosis, the treatment for election is surgical resection, and in some cases, I report the adjuvance of the use of radiotherapy, but the overall 5-year survival rate is about the 73%. And the last one is primary intraosseous carcinoma, not otherwise specified. This tumor may arise from epithelial lining of odontogenic cyst of de novo from intraosseous odontogenic rust. The mean of age of the presentation of this tumor is 52 years old, but the range of presentation is wide, is from 4 years to 76 years old. The 70% of the cases occur in men, and the zone of the that appears these tumors in 92% is mandible in the posterior side. It has a progressive swelling, it presents with pain or loosening and movement of the teeth, and cervical nodal metastases are really common in these tumors. It has an aggressive behavior. It's one of the most aggressive of the odontogenic carcinomas. The overall survival to 4 years is about the 40%, and to 2020, only 119 cases were reported. In the image, we saw a radiolucency cystic-like area with a pattern above destruction that had or could have well-defined margins, a difference between another tumors. The histological findings are very important because usually remember the histology, remember a conventional squamous cell carcinoma, but with a high grade. This is a case of a 42-year-old male that has this swelling on the mandible, on the posterior region, on the right side. There is no ulceration. But the most important finding of this lesion is that 2 years before to these clinical photographs, This is the radiography of the patient. The patient was attended by another doctor. So take a radiography and say, this is an inflammatory lesion. So you need endodontic treatment, and that's all. So the patient conserved the radiography, and we saw that, yeah, there has a radiolucency, unilocular area associated with the root of the first molar. The lesion is well defined, but at the moment of the clinical photographs, and at the moment as we saw the patient, the image changed. We saw, yeah, radiolucency, but it's ill-defined and extends to the second and inclusive third molar. Oral mucosa that recovered the lesion was intact. But over the oral mucosa, so the inflammatory cells like lymphocytes and plasmatic cells, some collagen, but behind the collagen, we saw the proliferation of these nets, these islands of epithelial cells. And some areas we saw this epithelial that remember an odontogenic cyst or odontogenic inflammatory cyst lesion, but was only in a little bit zones. At high power, we saw that the pleomorphism was really marked in this tumor, and the presence of atypical mitosis was also a finding in this tumor. We performed immunohistochemistry for cytokeratin 19 that we saw was positive in the nest of the tumor properly, but in the cover epithelial is negative. So for this tumor, the 40% have metastasis as the present of diagnosis. So the prognostic is bad for the patients. The surgical resection is the treatment for election. And in conclusion, this group of tumors are a rare group of tumors, but are important to know because all of them have different clinical characteristics, different clinical behavior, and histological features. All of them have an aggressive surgical approach, and it's important to consider differential diagnosis when we saw the slice of these tumors. Thanks again for the invitation to the Oral Pathology 360 organization. Thank you very much.
God, I'm muted again. I am sorry. For how long have I been muted? For the whole time. Yes. Right. I seem to be doing this again, but at least it saved you all from hearing my mic fall. Okay. So, right, you did see you saw the winners of the giveaway, which were chosen by the system. I also welcomed everybody and I thank you all for being here. I'm going to just repeat those. Dr. Ratu, who is with us, Dr. Priyanka, Dr. Varun, Dr. Nasir, Dr. Eliza, Dr. Sudindra, Dr. Usmani. Yes, all of you very welcome. And well, you did see the giveaway, so there's not much point in running that again. But okay, so let's go on with what else is happening. And just in case you are interested in attending the master class, well, we still have a few seats left, although there are not many because we have kept this limited to less than 100. So the seats are almost full. If you do want to, please go ahead and go to the website and complete your registration. On the other hand, we have only 1 day to go for filling or for applying to our social media leadership free 6-month program. If you want to apply for that, there we have received already over 50 applications, but I am not going to open any of them until the day closes tomorrow. So after that, we will start looking and making a choice. It is still open. You can go ahead and, well, apply if you're interested. And the other part is still going on, is that there is an option to contribute on the website, whether you can contribute financially or by giving your some ideas as to topics, experts. We may not necessarily use all of them right away, but it will be a good idea for us to collect and keep the information, and when required we will use them, and we will thank you for those ideas. On the other hand, what you can do definitely to help is to share the videos, to comment, to like, and all of that also will make a difference. Last week, like I had mentioned, anytime we have any support that comes our way and any kind support, we will thank those who do contribute. And last week we received a very kind contribution from Dr. Divya Upala. And the last, for everyone who may want to connect with us, there are many ways. You can send us an email at info@oralpathology360.com. There is also, of course, my own email, which is also there. And then you can connect with us using our handle, which whether on Facebook, on YouTube, on LinkedIn, and on Instagram. Everywhere you will find us with the handle at Oral Pathology 360. So do come and connect with us. We are always happy to meet and connect. Right, we have come almost to the end. Does anyone want to comment on anything or say anything? Yes, Dr. Sudhindra, I had forgotten to turn on my mic. What to do? I keep it off so that there is no noise disturbing the the video being played of the lecture, and then sometimes I forget to put it on. I sorry for that, folks. Okay, so let me share with you what is next. So next week is going to be the second edition of the town hall, where basically we are going to discuss with you what we are going to do, what we have been doing, and what you can expect. That also keeps me on my toes. Now I have to think of what I'm going to bring and share with you all next week. So I have to make sure I add something new. All right. And the next thing, of course, we have reached the end now. So let me say thank you for watching. Thank you for being with us. If you liked the lecture today, please hit the like so Dr. Yameli knows you did like her lecture. And right, we are good to go, I guess. If there is nothing, I don't really think there is. Right, I do hope I will see you all next week. You only have me next week, so that is that. And with that, let me say bye, everybody. Have a wonderful week and see you on coming Tuesday.